Hello and welcome to another intensive care hotline and intensive care at home emergency questions and answers for families in intensive care and intensive care at home. My name is Patrick Hutzel from intensivecarehotline.com and intensivecareathome.com, and I am here to answer your questions live on this live stream. But I'm also here to answer any questions that you might have after the call. You can email us any questions and then I will get to them in other videos as well. But this is your opportunity to talk to me directly, which you can do if you click on the StreamYard link that I just posted in the chat pad, and you can contact with me directly here and talk to me directly. Now, what makes me qualified to host a show, emergency questions and answers for families in ICU and intensive care at home? What makes me qualified is I am a critical care nurse by background. I have been working in critical care nursing for 25 years in 3 different countries, where I worked as a nurse manager for over 5 years in intensive care, and I've been working or been consulting and advocating for families in intensive care since 2013 here at intensivecarehotline.com. And I can very confidently say that we have saved many lives with our consulting and advocacy. And you can verify that on our testimonial section at intensivecarehotline.com, and you can also verify it on our intensivecarehotline.com podcast section where we have done client interviews. I'm also the founder and managing director of Intensive Care at Home. You can find more information at intensivecareathome.com. With Intensive Care at Home, we are sending our critical care nurses into the home predominantly for long-term ventilation, tracheostomy without ventilation, non-invasive ventilation, BiPAP, CPAP, home TPN, PEEK line, Hickman's line, central line, and portacath management. We're also providing cough assist management at home, nasogastric tube, PEG tube, PEG tube management, and palliative care at home. We're also providing Level 2 and Level 3 NDA support coordination with intensive care at home. We are currently operating all around Australia in all major capital cities as well as in all regional and rural areas. We are an NDIS approved provider. Now, also, if you want to support the work that I'm doing here, like the video, subscribe to my YouTube channel, share the video with anyone that benefits from it. Of course, spread the word that there is help out there for families in intensive care and intensive care at home. Same with intensive care at home. We have saved many lives with our nursing service at home. So, without further ado, let's get into today's questions that have come in during the week or that we get via email, sometimes even via phone call. Depends how people reach out or how people prefer to reach out. In any case, or if you have any questions, type them into the chat pad or connect with me live here on the StreamYard link. So, first question here from Leonie, who says, "Hi Patrick, my dad had a tracheostomy for 1 month after he recovered from a pneumonia. He still needs 1 liter of oxygen to support his breathing. Sometimes his oxygen levels dip down after physiotherapy. How can he be weaned off the tracheostomy? What are the best nutritional supplements we can give for him, as he lost weight drastically in the last 2 months? My dad is 83 years of age." So, thank you so much for sharing this, Leonie. That's really wonderful. It's a big step that your dad is recovering from the pneumonia and is using minimal oxygen support. Given his age and recent health challenges, careful planning is essential for weaning him off the tracheostomy and rebuilding his strength. So, weaning him off the tracheostomy. Here are some steps typically followed under medical and nursing supervision. Assessment by a respiratory physician, pulmonologist, respiratory therapist if you're in the US, and by obviously critical care nurses. They evaluate your dad's airway patency, cough strength, and his ability to manage his secretions. They assess his oxygen needs and tolerance during rest and activity, and they will be monitored. Capping trials. A speaking valve or a cap is placed on the tracheostomy tube for increasing durations, forcing air through the upper airway. So what does that look like? I'll show you what that looks like. So this is what a tracheostomy looks like. Okay. And I'll show you what a capping trial would look like. So once someone is off the ventilator, so this is what a tracheostomy looks like, right? Patient can breathe through the tracheostomy. A capping trial is that the cuff needs to be down, the balloon. So I'll just inflate the balloon so you can see when the balloon is inflated, all air needs to go through the pipe here, through the tracheostomy tube. Now, when a tracheostomy is capped, the first thing that needs to happen is cuff down. You can see cuff up, cuff down, so that patients can also swallow, right? They need to go through swallowing assessments, but that all needs to happen as well. So a cap trial basically means that instead of breathing through the tube here, a cap will be put on. I'll show you that. Right, you can see now it's blocked, and then the patient needs to breathe either through the nose or next to the tracheostomy, right? But the patient is being forced to breathe without the help of a tracheostomy, and that will show everyone whether the patient is ready to have the tracheostomy removed or not. So if your dad tolerates this without breathing distress or oxygen desaturation, decannulation or tube removal can be considered. Next, reducing oxygen dependency. Monitor and gradually reduce supplemental oxygen as tolerated. Observe how he handles physiotherapy or exertion. Next, pulmonary rehabilitation. Controlled breathing exercises, chest physiotherapy, and mild aerobic activity, bed or chair-based, help increase lung strength. And of course, the sooner a patient can move on to walking, the better. Next, what are other decannulation criteria? Of course, stable vital signs, adequate oxygenation on room air or minimal support, effective cough and secretion clearance, tolerance of capped tracheostomy for several hours. Always consult your dad's care team before initiating or advancing any weaning steps. Right? So next, you had a question around nutritional support for weight gain and recovery. So since your dad experiences significant weight loss, focus on high calorie, high protein, nutrient dense nutrition. Oral supplements, if safe to swallow, that's why I said, your dad needs to go through a swallowing assessment as part of having the tracheostomy removed. So what can be given? Ensure Plus boost high protein, calorie dense and easy to digest. Protein X or protein powder, add to meals or shakes. Glucerna for diabetic patients manages blood sugar while providing nutrients. Next, homemade high-calorie options such as smoothies, Greek yogurt, nut butter, banana, oats, protein powder. Soups, add cream, eggs or powdered milk for calorie boosts. Soft snacks, avocados, boiled eggs, cheese, mashed potatoes with butter. Now, if your dad still needs tube feeding, such as PEG or nasogastric tubes still in place, consider formulas like Gevity, Nutrient, or Isosource, which offer balanced nutrition. Add modular supplements, protein, fiber, or calorie boosters under dietitian supervision. Also check his vitamin D, B12, and zinc levels, as deficiencies can affect strength and healing. Now, if your dad, for whatever reason, cannot have the tracheostomy removed, then you should seriously consider using intensive care at home, right? With intensive care at home, like I said, we are providing home care services for long-term ventilated adults and children, predominantly with tracheostomies, but we're also providing home care services for patients with tracheostomy that are not ventilated, right? Which is a situation with your dad's case, And The best case scenario here is, of course, have the tracheostomy removed for your dad, get his weight up to speed, and then go home. But like I said, if tracheostomy removal for whatever reason cannot be achieved, then you should consider intensive care at home as an option to get your dad home from his long stay in hospital, or in ICU, I should say, right? And, you know, we have clients at home that are in a similar situation where the tracheostomy cannot come out just as yet, or in some situations can never come out. But, you know, in this situation, I do believe you have reason to be optimistic to have that tracheostomy removed for your dad at some point, right? And imagine how much better recovery might be in a home care environment, far away from the noise and the hustle and bustle of an ICU and a hospital, you know, where care can be tailored towards your needs, right? And where care is delivered according to your needs and according to your requirements. You know, in a hospital, it's often a one size fits all. In a hospital, you would have seen by now that your dad is having a different nurse every day and that there's no consistency, and that often contributes to the delays you might see in progress. Imagine your dad has the same caliber of staff than he gets in a hospital or in an ICU, but has that care delivered, number one, in the comfort of his own home, and has regular people coming over and over again, which get to know your dad, get to know his preferences, get to know his likes and dislikes, get to know him as a person, right? And then care can be structured so much better as opposed to a hospital and an ICU, right? Consistency is very important when delivering care, right? Like I said, in an ICU, and I've worked in ICU for over 20 years myself, all around the world, you know, like people come and go, and there's no consistency. Whereas with intensive care at home, we've made it our specialty to create teams around clients, right? Where the clients are involved in the selection process, where the clients are involved in, you know, creating their own care plans and making sure they've got the team and the staff around them that they know, like, and trust. And then it's much easier to work towards the goals that you want to work towards. In your case, there's Leonie, you want to work towards taking away your dad's tracheostomy, removing it, you know, but it's probably not quite there yet. You know, I'm just giving you options here. If your dad can have the tracheostomy removed while he's in hospital, your job taking him home will be so much easier, right? Will be so much easier. Half of your problems will be gone, you know. So I hope that helps and clarifies what you need to do for your dad, you know. Okay, so here is another email from Katrina, who says, "Hi Patrick, ICU is mentioning they're putting my 71-year-old mum in an acute care rehabilitation, or LTAC. She had a spinal cord injury and is paralyzed from her chest down. She was intubated and now she has a tracheostomy. They are trying to wean her from the ventilator, but have only had 4 hours of success. One of your articles says a long-term acute care facility should be avoided. She's on Medicare. The hospital says it will be better for her to provide rehab in the LTAC. What are your thoughts?" Thank you, Katrina, for sharing your mum's situation. So I'm very sorry that you have to navigate this, because I understand from my extensive experience that your mum is in an extremely vulnerable situation. So So here's what I think you need to know to make an informed decision. So what's a long-term acute care hospital, also known as LTAC? So LTACs are designed for patients who are too medically fragile for regular rehab, right? And ICUs, and I should also say that, I need to go one step back, sorry. LTACs are unique to the United States. LTACs do not exist in other English-speaking countries. So, you know, in the US, when patients in ICU have a tracheostomy, ICUs want to send them to LTAC as quickly as possible. That's at least our experience here, right? And it's dangerous. It is absolutely dangerous for patients and families, because it is, from my extensive experience, it is negligent for a critically ill patient with a tracheostomy and a nasogastric tube or a PEG tube going to an LTAC. LTACs are not equipped to go to look after ventilated and tracheostomy patients. They need critical care teams around them, critical care nurses, critical care doctors. In the US, they need respiratory therapists. And but the reality is that, you know, LTACs are not even the beta version of a nursing home. I've done a YouTube live maybe 12 months ago now with the title 10 Reasons Why LTACs in the US Are a Scam. And I stand by every word that I said there, right? LTACs pretend they can continue ventilator weaning. They can continue with any wound care that's needed. And they can continue with basic physical therapy. However, the quality of those LTACs, not only does it vary widely, I argue it's non-existent. The quality is not existent. And most patients experience poor outcomes due to lower staffing levels and fewer skills and less aggressive therapy. If your loved one is in intensive care needing to be weaned off a ventilator and a tracheostomy, the best place to wean them off the ventilator and the tracheostomy is in that LTAC, right? Hands down, right? Hands down. So, you know, it is not good to have your loved one go to LTAC, full stop. And we have helped many clients in the US to put a stop to their loved ones going from ICU to LTAC simply with our advocacy, right? And that's why I keep saying, you know, I'm not exaggerating when I'm saying we have saved many lives for our clients. In ICU, right? We have saved many lives, you know. Do not let your loved one go to LTAC. You know, let your loved one go to LTAC, and get help if you feel like you have no other choice, but let them go to LTAC. You always have a choice. You always have a choice to have your loved one stay in ICU, right? But like I said, with our consulting and advocacy, we have saved so many lives by keeping their loved ones in ICU. You know, it's interesting that when I speak to clients, you know, they always start the conversation, or they often start the conversation, whether it comes to, you know, having their loved ones go to LTAC, which they can put a stop to, you know, if they only followed advice. They always say, oh, I don't have a choice. You always have a choice. You always have a choice. You know, the biggest challenge that I can see is mindset and weak belief systems, right? If you approach every situation in life with everything in life is negotiable, you approach it very differently, as opposed to if you keep telling yourself, I don't have a choice, right? So often your mindset is your biggest enemy, nothing else. It's just your mindset. ICUs approach it from a mindset of, well, we can do whatever we want, which is not true. Healthcare is highly regulated, right? The minute you challenge ICU teams, you will see a vastly different result. If you don't challenge, they will walk all over you, right? And it just comes down to breaking down clinical information and advocating from a clinical perspective. That's what it all comes down to. Letting your loved one go from ICU to LTAC because they are ventilated, have a tracheostomy, have a PEG tube or a nasogastric tube. Sheer insanity. It is sheer insanity. And if you approach it with, oh, I don't have a choice, then you don't. Then you don't, for sure. But you just need to look at our testimonial section at intensivecarehotline.com. You just need to look at our podcast section at intensivecarehotline.com, where we've done client interviews, how we help them to keep their loved ones out of LTAC. Right? If you keep telling yourself you don't have a choice, there's not much I can do. But if you keep telling yourself, yep, we'll turn this around, much better mindset to come from. Much better mindset to come from. It's also a lot of families, they come to us and they say, oh, look, we can't get access to medical records. I call nonsense straight out, right? We never had a problem getting medical records for our clients, right? Never. It's a right, not a privilege. You approach it from a level of, that's my right, not a privilege, right? You will see outcomes change, right? You will see outcomes change if you change your mindset, right? The biggest challenge for families in intensive care is that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. It's exactly what you're up against. You don't even know that managing intensive care teams is an option, right? You don't even know because you don't believe in it, right? So, one of your biggest challenges here is change your mindset. So, coming back to the email from Katrina. So your mom's ventilator dependence and paralysis make her really ineligible to go to an LTAC, right? It is sheer madness sending her to an LTAC. So case in point, when we talk to our clients and families in intensive care and in LTAC, they tell us that when their loved ones have gone to LTAC before they found out about us, for example, they went into LTAC and then they bounced back into ICU within 24 or 48 hours. Which is a clear sign they should have never gone to LTAC in the first place, right? Most LTACs, when you look on their websites, they quote unquote specialize on ventilation weaning. Nothing could be further from the truth. I urge you to look up the online reviews for LTACs. Compare to what they're advertising on their website to what the Google reviews say. I strongly urge you to compare that. Right? So, why are they getting those feedbacks? Why are families reporting negative feedback about LTAC? Well, quite simple, right? They don't have the skills, they don't have the knowledge, they don't have the infrastructure, right? So why am I saying that, and what's the evidence behind what I'm saying? So for example, when you look on our website at intensivecarehome.com, you will find a section, the mechanical home ventilation guidelines. The mechanical home ventilation guidelines clearly outline that in a home care environment, only critical care nurses with a minimum of 2 years critical care nursing experience can safely look after ventilated and tracheostomy clients at home 24/7. It has to be 24/7. So in an LTAC, right, it's not evidence-based. Because in an LTAC, what you will find is there are general RNs with no or very limited ICU experience or even nursing aides providing care to a ventilated tracheostomy patient that needs ICU nurses 24 hours a day, right? That is sheer and utter madness, right? And in ICU, you're going from 1:1, 1:2 nurse to patient ratio to a 1:4, 1:5, sometimes even 1:10 nurse to patient ratio for ventilated patients. This is just madness. It is absolute madness. It is like flying the airplane with a cabin crew instead of the pilot, right? It is absolute madness what's happening in LTACs, right? Also, what is important for you to know, again, this is for our US audience, right? What the ICUs and the LTACs are not telling you in the beginning is the minute your loved one enters an LTAC, the clock is ticking again. The clock is ticking again. There often patients get another 30 days to then be discharged to a SNF, to a skilled nursing facility. So ICU is giving you the sales pitch, oh, let's go to an LTAC and let your loved one wean off the ventilator because we can't do it, right? Well, that's a lie. That's number one. Number two, LTACs won't do it. And then after 2 weeks in LTAC, they say, oh yeah, now your loved one needs to go to a skilled nursing facility or a SNF where things go from bad to worse. Okay, things go from bad to worse, right? So I don't think there's even a handful of LTACs in the US, not even a handful of LTACs out of probably out of hundreds that do ventilation weaning well and that actually get results for patients when they're long-term ventilated with a tracheostomy. So there are huge red flags if the hospital is pressuring you or saying Medicare requires transfer. Be very cautious. Number one, you have appeal rights. Okay, it's number one. Number two, with those appeal rights also come, extension of Medicare in ICU, right? If it's clinically necessary. Most Medicare patients in the US have 60 days of ICU, but if it's clinically needed and necessary to stay longer than 60 days, my experience is patients can stay longer than 60 days, right? So, you also need to ask the ICU to give you more than one LTAC to visit so you can make up your own mind and ask them what are the results, what are their receipts, right? Don't accept vague answers, right? Don't accept vague answers. Also, you could ask for a meeting, so they lay out the land for you, what they're doing to keep your loved one treated in ICU. Get a weaning plan, right? Like I said, the minute you start researching specific LTACs, the more you're digging, I argue, the more you will be digging up dirt. Another thing you can do is go to and visit an LTAC. Go and see for yourself. Talk to other families, right? But get a weaning plan from the ICU, which I think is really important. Get a weaning plan from the ICU. That's your best bet. Tom, nice to see you again. Amen on the ICU to LTAC to SNF warning. Patients are indeed just punching their ticket for return to ICU or the morgue. Yes, that's very bleak, Tom. That's very bleak. You have put it even much more bleak than I have. But I think that's also the reality. And, we need to speak the truth here. and you are in the US and you have first-hand experience. I have first-hand experience too, because I'm talking to people in the US every day. But I know you've been through it with your son, and it's just the system is so broken. Unfortunately, the system is so broken. It is just needs to be fixed. But the first step here is that people need to wake up that the system is broken. I was talking to someone this week. Who was I talking to? I was talking to a lady. Yes, I was talking to a lady in South Carolina, and they're basically asking her to send her daughter to Georgia to an LTAC. It is madness. It is sheer and utter madness to expect from families to send their loved ones to another state, to 6 hours away. And I know this particular lady, while she's very unwell, she's got 2 young kids. And they basically just say, well, your only option here is to go to an LTAC in Georgia, 6 hours away, or whatever. It is just unbelievable. That's why I'm saying the system is absolutely broken. And people need to be aware of it. And it's not the first time. I'm hearing it all the time, where depending on where people are in the US, they're telling me, oh, I'm in Illinois, and now they want to send my family member to Michigan or to New York. Or I've seen all sorts of things, and if people are not aware of it, they're getting in all sorts of trouble. I'm sure, Tom, you have, you had to make a lot of amends to get your son home to avoid the LTAC and SNF pathway, and if you hadn't taken matters into your own hands with nursing services, and I know you're doing a lot of work yourself there, God knows where your son might be today if it wasn't for you and your forward planning, probably, and your research probably as well. So watch out for LTACs. Watch out for LTACs. You must avoid them like the plague. And what is really important here is ICUs are often playing dumb as well. They're often playing dumb, and they say, oh, we can't wean patients off ventilation and tracheostomy. Well, the best place to wean someone off a ventilator and a trach is ICU. They're the experts on, ventilation, tracheostomy, weaning. They're the experts on it. So let's move on to the next question. If you have any questions, please type them into the chat pad or connect with me live here on the StreamYard link, and you can ask me questions live here. So I have another question from another client, which is along the same lines. The LTAC always comes up for questions for our clients in the US specifically, right? So another question is, does transferring a patient from ICU to LTAC without proper stabilization, i.e. patient is still unstable, without antibiotic therapy when needed, and without proper infection control practices, expose the patient to avoidable medical risk? Now, this is a very specific email or very specific question, because our client here is already implying that that there's no proper infection control mechanisms in LTAC, and I tend to agree. That there's not enough infection control practices in LTACs. You have lower skill levels, right? And that lower skill level often transfers into poor infection control practices as well. And then patients are at much higher risk getting infected, getting setbacks, potentially even die. So, but more specifically, transferring a patient from ICU to an LTAC without proper stabilization proper antibiotic therapy and infection control can expose a patient to significant avoidable medical risk, including but not limited to worsening of infections, of course. If an infection is not adequately treated or controlled, it can spread. Sepsis, pneumonia, progression, which is much harder to manage in an LTAC setting, right? So also bear in mind, for someone that's ventilated, there is a much higher risk of a ventilator-associated pneumonia, right? So, you know, and that's much easier treated in an ICU. Also, inadequate monitoring and inadequate training. So that means ICU level monitoring is much more intensive than what most LTACs are able to provide or can provide. A patient who isn't stable can deteriorate without timely intervention, and that's the problem. You know, LTACs are so poorly staffed that they can't intervene timely and appropriately, which ICUs can, right? So another reason why you should not go to an LTAC. Ask them for their staffing levels. Ask them for staff qualifications. You know, and you will see that it doesn't compare well to ICU qualified staff. Also, you will often see delayed treatment in LTACs, right? Again, necessary medications or interventions such as IV antibiotics, respiratory support are delayed or improperly managed in an LTAC during or after transfer. The patient's condition can worsen. This brings me back to my point that I said earlier. We have witnessed and heard of so many patients going from ICU to LTAC prematurely. They should have never gone in the first place. And they bounce back within 24 to 48 hours to ICU. And then, listen to this, they often bounce back to another ICU because the ICU that the patient was discharged from no longer has a bed available. Let that sink in. A critically ill patient goes from ICU to LTAC, needs ICU again within 24 to 48 hours because they've been prematurely discharged, right? And have been prematurely discharged and then bounce back again in another ICU. Basically, they are in 3 different places within 24, 48 hours. You know what a critically ill patient needs? They need consistency, and they need a team around them that gets to know them, to move them from point A to B, right? Not being shipped off to other places, you know, where they don't know the patient. You know, how would you feel as a patient if you're getting shipped from place to place where people need to get to know you, right? So, again, words of warning here. Also, increased risk of complications. Once again, where's that coming from? There's a much higher risk of complications because the LTACs don't have the staffing levels. They don't have the skill levels, right, to recognize complications, right? Because they're not monitoring, right? And that raises the risk of cardiac, respiratory, or metabolic complications, right? And like I said, readmissions to ICU, which increases morbidity, cost, and of course, emotional distress for patients and families, right? It's actually more expensive in the long run to have patients go from place to place and extend their periods of times when they are in hospitals and in ICU and in LTACs, right? Outcomes are generally speaking much better if patients have stable teams around them, right? So before any transfer, a comprehensive clinical assessment needs to confirm that the patient really benefits from an LTAC, right? And the findings there will most likely find they won't benefit, right? So, but I'm spinning this one step further even. I've created a formal objection letter you can use and adapt to delay transfer or avoid it completely based on the medical risks that are always there for a ventilated and tracheostomy client. So, and you can take that verbatim because we've tested this and it works. You can write, I'm writing on behalf of patient name who's currently under your care in the intensive care unit, put the hospital name in there. I am and my family is deeply concerned about the proposed transfer of, put the patient's name in there, to long-term acute care hospital at this time. As the patients, and then you put in your relationship, next of kin, object to the transfer based on the following unresolved and potentially dangerous medical issues: lack of clinical stabilization, put in patient's name, continues to exhibit unstable vital signs and clinical indicators such as mechanical ventilation, tracheostomy, fluctuating blood pressure, oxygen dependency, and put in any other, clinical complications that are needed, that need to be mentioned. But again, we can help you that by just looking at the medical records. Next, incomplete antibiotic therapy. Active infections such as pneumonia, sepsis have not been adequately treated or documented as resolved. Transferring my loved one mid-treatment significantly increases the risk of treatment failure or complications. And then inadequate infection control. There is insufficient evidence that my loved one's infections are contained or that appropriate isolation and monitoring procedures will be put in place to ensure a safe transfer and continuity of care in an LTAC. Next, risk of harm due to lower monitoring and care standards. LTAC facilities typically lack the acute level surveillance resources and monitoring required to manage complex or unstable patients, which increases the risk of clinical deterioration, readmission to ICU, or worse. I therefore respectfully insist that, insert your loved one's name, remain in the ICU until medically stabilized, weaned off the ventilator and the tracheostomy. Antibiotic and infection control plans are completed or well established, and a safe, coordinated transfer plan is in place. But prior to that, we would like to see a weaning plan to wean my family member off the ventilator. Please document this objection in the medical records and kindly confirm receipt of this email or letter and response from the attending medical team. I am prepared to escalate this matter to hospital administration and, if necessary, legal counsel to protect the patient's rights and safety. You could potentially also get the ethics committee involved, but you would have heard me say on this podcast that I'm not in high favor of ethics committees. And the reason I'm not in favor of ethics committees in hospitals in general is that they are not objective. They're not objective, and because they're hospital employees, right? They're hospital employees, and they can't be objective. You need someone that is clearly objective in their view. So, I have another question that came in from another client, but again, this is along the lines that we've just talked about: ICU versus LTAC. If an LTAC in the US fails to provide ICU level care for a ventilated patient with tracheostomy and the patient dies because of it, is this medical negligence? With everything that we've discussed so far, yes, it absolutely is medical negligence, right? But you could argue, is the error with the LTAC, or is the error with the ICU transferring the patient prematurely? Who's responsible for it? Who's accountable for it? Right? Is it the ICU? Is it the LTAC? So it is medical negligence, but whether it legally qualifies depends on several factors. Medical negligence or malpractice, generally speaking, happens when a healthcare provider breaches the accepted standards of care, and that breach directly causes injury or death. So for your situation, duty of care, an LTAC does have a duty to provide an appropriate level of care for ventilated patients, even though they are not in an ICU. Breach of duty. If the LTAC failed to monitor your loved one properly, responds to emergencies poorly, maintain the ventilator, or fail to recognize and treat critical conditions in ways that a reasonably competent LTAC should have, that would likely be a breach. Causation. You would have to show that the patient would likely not have died if the LTAC had provided ICU level care when it was medically necessary. For example, if the patient needed urgent interventions they were unable to provide. Damages. There must be actual harm in this case, i.e. patient's death. What's important? LTACs are not ICU level hospitals. They are designed for stable but still critical patients on paper. If a patient needed ICU level interventions like immediate critical care, complex ventilator management, or rapid resuscitation, and the LTAC failed to recognize the need or arrange urgent transfer to an ICU hospital, that could definitely be grounds for medical negligence. It often comes down to expert testimony. Another doctor would usually need to testify that the LTAC care fell below acceptable care standards. Examples where it might be negligence. They didn't have staff trained to manage sudden ventilator failure, and they don't. They delayed calling an ambulance. In the US, it's 911, or arranging ICU transfer when the patient is stabilized. They ignored alarms or signs of respiratory failure. They improperly managed secretions leading to airway blockage. Steps you can take if you believe this happened. Request the full medical records immediately, including nursing notes, ventilator logs, emergency response records. But here's the problem, you need to request access to medical records day one when you have a loved one critically ill in intensive care, so you're not getting into trouble in the first place. Consult advocacy or consulting services like intensivecarehotline.com and consult potentially with a medical malpractice attorney who specializes in hospital negligence. And consider an independent medical review. Many malpractice lawyers might have doctors they work with who can review what happened, but many don't. And that's where we come in. We review medical records here as well. So getting organized early is really important. Here is an outline of the evidence you want to collect to pursue a potential medical negligence case against the LTAC. Medical records complete set. Request all of the medical records, such as admission records. Reasons for transfer to LTAC, initial patient condition. Daily progress notes, doctor and nurse notes every shift. Respiratory therapy notes, ventilator checks, tracheostomy care, oxygen levels, suctioning. Vital signs logs, anytime there were drops in oxygen saturation, blood pressure, etc. Medication records, especially sedatives, antibiotics, emergency drugs. Ventilator logs, alarms triggered, mode changes, settings, and documentation of ventilator management. Emergency response records, codes called, rapid response team notes, if any, etc. Transfer requests or 911 calls or the absence of them. Death summary or death certificate, important for cause of death listed. Tip: do not just ask for a summary, ask for the entire chart and say all handwritten and electronic notes, respiratory logs, and monitor data. Policies and protocols. Ask in writing for the LTAC policy for managing trach patients on ventilators, their emergency transfer policy when patients deteriorate, or they refuse to give it. Your lawyer can subpoena it later and asking now shows seriousness. Staffing information. You'll want to find out nurse-to-patient ratios. At the time, should not be 1 nurse for 10 ventilated patients, for example, but that's often what it is. Qualifications of staff. Were they licensed respiratory therapists on site 24/7? Are there critical care nurses on site 24/7? Right? Understaffing or untrained staff is often a major negligence point. Witness accounts. If you or others witnessed anything such as alarms being ignored, delays in care, visible distress of a patient without response, write it down while it's still fresh. Date, time, what you saw or heard, names of the staff involved, if possible at all. Family observations can be powerful evidence later. Communication records, safe. Any emails, texts, or messages between you and the facility. Notes from meetings or calls with doctors, nurses, or administrators, especially if you raise concerns that were brushed off. Expert review. A malpractice attorney will usually hire a pulmonologist, critical care specialist, or LTAC expert to review the records. Get an expert opinion on whether the standard of care was breached. You don't need the expert yet. First, focus on gathering the documentation. Bonus tip. Timelines. Start building a simple timeline of events, date of LTAC admission, any worsening events, i.e. respiratory distress, dates, times of family visits or calls, date, time of death. It will help the medical malpractice lawyer to see the sequence of negligence. So, also, yes, before I forget about it, we're also working with a client currently where, once again, the ICU was very pushy to withdraw treatment on their loved one. And again, we politely but firmly objected. And the client is still alive, if anything, is slowly but surely waking up. Right? This is actually a client in the UK. And the UK is really the worst country at the moment when it comes to ICU treatment. They want to kill people left, right, and center while they're awake. Don't even talk to patients. Right? That leaves more interpretation for what that might be perceived as. Is it just palliative care, end of life situation, or is killing someone that's awake, that's not even being asked whether they want to live or die? Is that something else? Could that be perceived as homicide, as euthanasia, potentially even murder? I'm just asking the questions here, and I want you to ask the questions too. Right? It is very important that you ask the questions of what is really happening with your loved one's life and with your loved one's situation in ICU. Right? You do not want to fly blind under any circumstances, which is what most families in intensive care do. They come to us often when it's too late. Right? You cannot take chances when you have a loved one critically ill in ICU. You cannot take chances. Right? So just keep that in mind, that you need to ask for help day one, immediately. Don't come to us when it's too late. So, lastly, before I wrap this up, I always go for about an hour. Before I wrap this up, I also have a sample letter. You can formally request your loved one's medical records from an LTAC or from an ICU. Request for complete medical records. Put in your loved one's name, date of birth, dates of care at the facility or at the ICU, and then just write, Dear Medical Records Department, I'm writing to formally request a complete copy of the medical records for the above named patient during their stay at your facility. I'm the legal representative, next of kin healthcare proxy for the patient, and I am authorized to request and receive this information. Please include all records, both handwritten and electronic, including but not limited to admission records and intake documentation, physician and nursing progress notes, medication administration records, respiratory therapy notes and ventilator logs, vital sign logs and nursing assessments, laboratory and imaging reports, emergency response records, i.e. rapid response team code blue, records of any transfer requests or ambulance calls, communication logs between staff and family, death summary and or discharge summary, any documents related to hospital policies or procedures affecting care. Please provide the records in electronic format, PDF on USB or encrypted email if available, or just with a link to a website with the username and a password. If you require a fee, please notify me in advance. This request is made under my rights granted by the Health Insurance Portability and Accountability Act, also known as HIPAA. I expect the records within the allowed timeframe under federal and state law. If you need further confirmation of my authority or have any questions, you may contact me directly. Thank you for your attention to this request. Straightforward, very simple, but you can use it because we've used it with much success. Right? So do not give up. And like I said, do not wait for something to happen. Get access to medical records day one. Get that second opinion from us day one. Get us to review the medical records day one so we can guide you, we can handhold you through this once in a lifetime situation that you simply cannot afford to get wrong. You cannot afford to get this wrong. You know. So, before I wrap this up here today, I want to thank you for coming onto the show and for, attending this live call. If you have any questions, keep them sending in to intensivecarehotline.com or intensivecareathome.com, depending on which area you need help with. We can help you with Intensive Care Hotline, with Intensive Care at Home. Share this video with your friends and families or anyone that will benefit from it. I also do one-on-one consulting and advocacy for families in intensive care, or LTAC. We have a membership for families of critically ill patients in intensive care, where you have access to me and my team 24 hours a day in a membership area and via email. And that will help you to make informed decisions, have peace of mind, control, power, influence, making sure your loved one gets best care and treatment always. Right? So, very important that you stay one step ahead. The problem is most families in intensive care don't even believe that staying one step ahead is a possibility. That's part of your problem. That is part of your problem. Okay. Go and check out intensivecarehotline.com. You can call us there on one of the numbers on the top of our website, or send us an email to support@intensivecarehotline.com with your questions. Or you can contact us at intensivecareathome.com. Again, call us on one of the numbers on the top of our website, or send us an email to info@intensivecareathome.com with your needs. Like I said, with Intensive Care at Home, we're operating all around Australia. We're sending critical care nurses into the home 24 hours a day. And we're NDIS approved. But we're also getting funding through other funding bodies. Just contact us if you need anything. We're also providing level 2, level 3 NDIS support coordination, right? And I do these YouTube lives once a week, 10:30 a.m. Sydney, Melbourne time on a Sunday morning, which is 8:30 p.m. Eastern Standard Time on a Saturday night in the US, 8:30 p.m. on a Saturday night Eastern Standard Time, and 7:30 Central Time, 5:30 p.m. Pacific Time. Thank you for your support. Like, comment, subscribe, share the video, and I'll talk to you next week. Thank you for your support and take care.